So, well, thank you so much for having me today. I'm so happy to speak to all of you. It feels like that I was in your shoes not that long ago, but it was quite a ways ago. But time does fly by quickly. And so I'm happy to answer any questions you have, but I thought maybe I would just start with a little introduction of myself and my career, and then happy to open the floor up to any questions either through the chat or through the Zoom platform. So as Mohammed said, my name is Rachael Overcash. I'm a maternal fetal medicine physician and an OB-GYN. So as you enter your career in medicine, you realize that medicine is a very subspecialized. And so by training, I'm board certified in both obstetrics and gynecology and something called maternal fetal medicine. I graduated from NC State I have to look at my diplomas now, 2002. Actually, I apologize. I graduated in both 2001 and 2002. In 2001, the December semester, I graduated with my Bachelor in Science in Political Science. And then in 2002, in that May, I graduated with a degree in biochemistry. I'm from Raleigh originally. I went to Broughton High School, so anybody who's from Raleigh, my parents still live there. My dad was actually a professor at NC State in chemical engineering. So if anybody is a chemie major, my dad retired probably about 10 years ago now, but he was there for a long time. I am a third generation NC State grad. Both my grandfather, my father, and 4 uncles went to NC State, and myself, and I have 2 other cousins that went to NC State in my generation. So big time Wolfpackers, and still try to go to football games every year when there was in-person football games. So we weren't able to go last year because of COVID. After NC State, after I graduated, I actually did not start medical school right away. I took a little bit of a side track. I ended up doing my master's in public health. As I noted before, I was both a biochemistry and political science major. And so I had a very strong interest in health policy. And a lot of what I did while I was at NC State was within the student government. I was senior class president. I served as the chief of staff for the student body president. And so I did a lot with kind of policy and advocacy work while I was at NC State. And so I really wanted to translate that into health policy. And so I decided that I thought I would want a career in medicine that both involved policy and clinical care. So I got my master's in public health at Yale University. And then after I was at Yale, I went to the George Washington University here in DC for my medical school, where I stayed on for my residency in OB-GYN. And then while I was an OB-GYN resident, I decided I actually do not like gynecology, and decided what I really like is something called maternal fetal medicine, which basically is something called high-risk pregnancy. So I manage women who are high risk in their pregnancy, and that could be anywhere as simple as somebody who is 35 or older in their pregnancy, somebody who has twins. We currently have, I think, 3 sets of triplets, which is crazy. Women who have underlying chronic medical conditions that make their pregnancy more complicated, such as diabetes or high blood pressure, lupus, underlying kidney disease, HIV, recently COVID, a lot of COVID. And so after my residency at George Washington University, I went on to a 3-year fellowship in maternal fetal medicine at the University of California in San Diego. And then I graduated there in 2015 and then returned to the DC area, where I now work at MedStar Washington Hospital Center, which is the largest hospital here in the DC. We're part of MedStar Health, which is the 15th largest medical group in the country. We are a large tertiary care hospital in the district. We are also considered kind of a, what's the word I'm looking for? Like we see a lot of patients with public insurance or safety net hospital is what I was trying to look for. And so I see a lot of women from all different walks of life in my career. It's never boring. And I think that's an introduction to myself. I guess I'm happy to answer questions or give you some stories of patients I've taken care of, or whatever, whatever you would like me to do.
I actually have a question for you, Rachel, if you don't mind. What was one of the turnaways from gynecology? Like, what did you not like about it?
So I kind of, maybe I should answer that question, why I was interested in OB-GYN. So OB-GYN is a career that is very appealing in many ways because it is so multifaceted, meaning that the general OB-GYN can start in the morning in the office and then go to delivery, or is even, for many people don't understand that gynecologists or OB-GYNs also perform surgeries. So they would perform a hysterectomy, or if you had a cyst on your ovary, take that out. So there's also a surgical component to it. Obviously, we perform C-sections a lot. And so that appeal to me was being able to do kind of a whole range of medical practice and taking care of women over the course of their lifetime. As I started to practice it, I realized that gynecology, at least, I didn't really like operating. I didn't, it was something that, I was good at, but something I didn't really find I had that much passion for. And a lot of what gynecology is to deal with sometimes women with heavy bleeding or pelvic pain or fibroids. And it's something that I really didn't feel that passionate about or that excited about. But what I did find a lot of excitement about was managing these high-risk women, where we had to make critical decisions about, do we deliver them? Do we not? Do we watch? Women that you're then challenged to think about things outside of kind of normal obstetrics. So for example, today I had a patient who was describing to me about a motor vehicle accident she had in 2003 and how that's so much impacted her life and her mental health and the mental trauma she's had from that, and the number of surgical repairs and facial surgeries she had to have and spinal surgeries. And so that's something I don't see every day, but something that I can then discuss with her. How does that impact pregnancy? And I guess it's just not as much excitement in gynecology. But you have to train in both to do OB-GYN, and then you can choose to subspecialize.
Thank you so much for the explanation.
Of course.
I have a question as well. So are you technically an OB-GYN?
I am. So so another good example of what a good example would be like a cardiologist, right? So a cardiologist is a doctor who specializes in the heart, but that person still did a residency in internal medicine typically, and then they chose to go on and subspecialize in cardiology. And then even within cardiology, there's a lot of subspecialists. So somebody who is just a general cardiologist, somebody who does intervention. So like if you had a heart attack and you went to the hospital, you had to get a catheterization of your heart, that would be an interventional cardiologist that would do that. We even have cardiologists here that specialize in intensive care, people who specialize in people who have arrhythmias, so they're called electrophysiologists. So what you do when you graduate medical school is you choose a residency, and that's very generalized. And then from there, you can then choose to subspecialize. So in OB-GYN, you do an OB-GYN residency, and about 20% of the OB-GYN residents elect to do a subspecialty. And in OB-GYN, those subspecialties are maternal fetal medicine, something called GYN oncology, which would be, they would do no obstetrics, they would just do like GYN cancer surgeries. There's something called infertility, reproductive endocrinology infertility. So these are the doctors who are doing all the IVF There's another specialty in something called urogynecology, which is again just surgical gynecology, and there's different specialties. So I am technically a boarded OB-GYN and maternal fetal medicine specialist, but I don't practice gynecology anymore.
Okay, that makes sense. Thank you.
Yeah, of course.
So what is the difference between gynecology and obstetrics?
Say, I couldn't hear the question, Annie.
Sorry, can you hear me now?
Yes,
Okay, so what exactly is the difference between obstetrics and gynecology?
of course. That's a great question. So they are definitely interconnected, but technically obstetricians are people who just work with women in their pregnancies. So an OB-GYN we only take care of women. We don't take care of any men. And an obstetrician is somebody who just takes care of women in their pregnancy. But really, there's no such thing as just an obstetrician. Like, they typically are going to be a general OB-GYN who practices obstetrics and gynecology, and then there's the specialist who will do, like me, maternal fetal medicine. So, and a gynecologist is somebody that you would go to for your woman checks that you go every year to get your pap smears, your pelvic exams. Those are the people that would that if you had pelvic pain or heavy bleeding, those are people who you would go see to get advice on how to treat that. So, but you can't just specialize in obstetrics or gynecology. You do both, and then you subspecialize beyond there. So probably for all the women on this call, you probably see an OB-GYN who's a general OB-GYN. You probably may not have seen, unless you've been pregnant, somebody like me yet.
I have a question for you.
Yes.
In medical school, what kind of pushed you towards obstetrics and gynecology? And I guess, yeah, that's my biggest question is in med school, kind of like what clicked for you for that?
Yeah, that's a great question. So when I was actually getting my master's in public health at Yale, I had a mentor who was an OB-GYN, and he introduced me to the world of OB-GYN, and the fact that it was what I initially found so interesting is that that you got to take care of women over the course of their lifetime, that you were able to do both what we consider primary care, surgery, deliveries, even over the course of a day or even a week. So there was so much variety that I think was so exciting. It is a type of medicine that I think is for people who can move fast and who can multitask well, although I don't think anybody can really multitask that well in life. But when you're running labor and delivery and on labor and delivery, it is incredibly fast paced with things happening all the time. And decisions have to be made very quickly. And so it is a profession where it is suited for certain type of people who like that fast pace and that quick thought process. If you are somebody who wants to sit down and kind of dive deep into things and really be very analytical, I would say OB-GYN is probably not the greatest field. There are lots of great fields in medicine that allow for that, but I would kind of correlate OB-GYN and the ER to be very similar. It's quick. You have to make decisions quickly. Our breadth of our diseases are not that large, but you have to know them well, and you have to be able to very quickly evaluate and try to make decisions.
Okay, awesome. Thank you.
Yeah. So I see Neil said, what aspect of your CV do you think was most important to help being accepted in medical school? So for me, and it's been a while. When I was at George Washington, I was involved with the medical school admissions, and now here at MedStar Washington Hospital Center, we are. MedStar is also owns, I guess, Georgetown University Hospital. So we have OB-GYN residents that are both joint between us here in Georgetown, and also our fellows are both. So I see a lot of applicants, at least for those positions, not as much for med school anymore. But for me, I think there's no doubt GPA is still important. I'm not sure, even in COVID times, if the MCAT's being given, if that's something that's still a priority. I know a lot of the Ivies right now are actually not asking for SATs anymore, which I think is fascinating. So, I mean, MCAT scores, hitting a threshold is still important, I assume, but I think it's overall a combination of your GPA. I think it's doing something, showing something in your CV that you have passion about, and something that you, even if it's just one thing that you really dove in and you know well. I think the applicants that I always hesitate on is when I talk to them about their research project and they can't explain it because they were just put on it because they were working in the lab that summer, or just helped collect very superficial data for them, but can't explain why and what it was about and what the impact was, and has really thought critically about it. So those are hard to read on a CV, but when you interview somebody, that all comes out. So for me, whatever you put on your CV, you should know well, and you should have been invested in it and be passionate about it, because that stuff will come out eventually in an interview if it's very superficial. So you mentioned earlier you were interested in public health and public policy. Does that passion still show what you currently do? So this is from Maggie. So it does, not in as formal of a way now. So right now here in the district, and is in around the country, so much of what we struggle with in obstetrics is to do with maternal and infant mortality, and mainly maternal mortality. So DC, unfortunately, has quite a high rate of maternal mortality. Now it's still 1 in 10,000 births, but the fact that, you know, we have women dying in the district after giving childbirth within the year is still a tragedy. And so in my current role, I've been fortunate enough to be involved with some of the efforts to deal with maternal mortality in the city. And most recently, we have a large grant from the District of Columbia to address the rate of preterm birth in the city and try to create support interventions to decrease that rate of preterm birth. So although I'm not a direct public health official and not directly formulating policy, I'm still involved with the advocacy of it within the district and trying to give at least the medical perspective of how things can be improved when it comes to decreasing the rate of preterm birth and maternal mortality. So Taylor asks, how do you deal with the tragedies of these women, or do you just need to remember it's part of the job? It's hard. So I think for a long time in medicine, they told you it's kind of like it's a part of the job. You just have to deal with it. And there was really not acknowledgement of what we call the, there's a term for it, and I'm just blanking right now. It's called the second responder. It has a term, and I can't remember it now. But for example, most recently I did a C-section on a patient whose BMI was like 50. So, you know, she weighed close to 250 pounds, and the delivery was challenging. It was incredibly hard. And it took me 8 minutes to get the baby out. That's, I mean, none of you have probably seen a section, but that's too long. So typically once we make the incision on the uterus, baby's delivered within 2 minutes. And when you start when it's hard to get the baby out, what happens is you're worried about the baby's not getting enough blood from the placenta, which is what gives us its oxygen, and the baby can be at risk for having poor oxygenation to blood, can be at risk for being anemic because it's not getting enough blood, and can also be at risk for neurological injury that could leave it, you know, permanently damaged. And so in the moment when you're dealing with this, it's like time stands still. You are struggling in every way to get this baby out, and it's somebody that's big, and you're trying all the things you can. And what's great about medicine is that medicine is a team sport. And so you have people there giving you suggestions, but also saying, hey, do you need another physician to come in and help you? And so in this recent case, we had somebody else come in and help me, and we were able to deliver the baby successfully, but it's still been 8 minutes. And the baby looked fine after she delivered. The rest of the surgery went uncomplicated, but then later that day, I heard the baby had to go to Children's National Medical Center, which is the hospital next door to ours, which is the big children's hospital, like UNC Children's in North Carolina, to get something called cooling, because they were worried that the baby had a brain injury. And that was something that was really traumatic, because it's like you think to yourself, did I, like, should I have done differently about the approach? Should I have, should I have done this? Should I have done that? Should I have placed something else on? And in the moment, it's hard to see that, but when you reflect on that, it's hard. And so what we do now is, instead of just saying, okay, well, there's nothing I can do, I think medicine now has changed, where they try to have, we have debriefings, we have, support services that we can reach out to if we're having, feeling that this is really taking a toll on us. Because the reality is that medicine has acknowledged that burnout is a huge issue, that physicians burn out at incredibly high rates. Women physicians burn out at higher rates, probably because of the stress that also placed on of having a family. And so the medical field and these major hospital systems understand, like, if a physician leaves, it costs them really more money and time to hire a new physician than just probably providing the support services to that physician in the moment. And so the idea of physician well-being and this is even medical school, medical student well-being, resident well-being has really come to the forefront. And so in my job, yeah, there's stress. There's no doubt there's stress. There's stress probably on a daily basis, but I think some of it is putting in perspective, but some of it is knowing that you're not always going to have the answers, and that you need to ask for help, and that help can be another colleague, or that can be support from your hospital system, so that you can avoid burnout and try to take the best care of your patients that you can.
I had another question.
Yeah.
What was a typical week like for you as a resident?
So I would say an OB-GYN resident is not an easy residency. I would say it's probably one of the harder ones up there with like a general surgery residency. So a typical week is, depending on the hospital we were at, but I would say we typically work 60 to 70 hours. We would, if we were covering labor and delivery, we would typically sign out, I think, at 7 or 8 a.m. and you would work till 7 or 8 p.m. and then sign out again, and then come back the next morning, pre-round on your patients, or I should say round on the patients before you started your shift. You are required to have 1 day off in 7. So typically how most residency programs do that is they average that out over 4 months or 4 weeks. So in a given block or a given month, you typically like one they call golden weekend off. But that's counteracted by, working a full weekend. My residency, we started doing 24 hours when there was times where we would do 24 hours on Friday and come back and do a 24-hour on Sunday. And those were the worst weekends. But we switched it to subsequently 12-hour shifts. The current program that I work at now, I don't take call like that anymore, but my residents, they work still 24 hours on the weekends. And then they have something called night shift. I don't know if y'all are familiar with night shifts, but this is a typical, like, emergency medicine would do this. OB-GYN residency is different from like a surgical residency or like a medicine residency where there's a smaller team covering at night, because patients aren't active, right? So they get admitted from the, like a medicine resident would, medicine patient would come into the ER. the patient had a heart attack. Okay, they need to be admitted and observed or whatever. And so then the medicine team admits them, and then they kind of sit overnight, and then the team in the morning takes over the care. Thing in when you're covering labor and delivery is that patients are active. They are laboring, they are pushing, there is always something going on. And so you're up working the whole time. And so, so it's it's 3 or 4 people on at night, but we do night shifts so that you'll do what we call a, night float is what they call it, where you're at a month at a time, you'll do nights. You'll start Sunday night and end Friday morning. And then there's a separate team that covers the GYN pager. So if any, there's surgeries during the day, but at night, if anybody comes to the emergency room that has a GYN issue, then there's a separate team that goes down and usually evaluates them.
Okay, thank you. Did you feel like you had a good work-life balance during residency, or has that gotten better for you? Or
yeah, I mean, my mantra in life has always been like work hard, play hard. I think in undergrad, I did the same thing. I was incredibly involved and busy and doing a bunch of stuff on campus. And so, so that's always been kind of how I've enjoyed living. So yeah, did I have a normal 20s as somebody who lived in DC? No, that had like every weekend off and go to happy hour all the time. No, but I think, try to take advantage of much as I could in residency. And we have 2 kids now. We didn't have kids then, and so you definitely have more freedom in that sense. But yeah, you can make it work for sure. And it's important because ultimately, even in my current job, my current hours are very good. I work basically 8 to 5:30, only Monday through Friday. So I get most of my weekends off, except if I'm on call, and then I just come in like for a few hours on the weekends. But career medicine, whatever you choose, is you're gonna work hard.
yeah, okay, thank you so much.
Yeah, of course.
Hello, Dr. Overcash.
Hi.
So, I wanted to go back to talking about your master's in public health, and I was gonna ask, like, if you were to, or like, let's say you wanted to be exercising your master's in public health a little bit more, do you have the flexibility and like, do you have the freedom, I guess, from the hospital to, I guess, stop practicing obstetrics a little and start working with your research or, policy making a little bit more?
Yeah, that's a good question. So the short answer is no. But so unfortunately, medicine, and this is not the same, I feel like, in, so my hospital, we are an academic medical institute. But for example, like your professors now at NC State, they get a base salary from the university, and then they can support that salary. They either had to teach or they have to do research, right? Like to support that salary. In medicine, that's the same thing. You either had to see patients or you have to get research support. And so my salary is based on my clinical productivity. So it's based on the number of patients I see per week. And that it's a very simplistic look, but that's basically what it is. And that's unfortunately not unique to my hospital. That's basically most academic centers around the country. Is your work is based on your clinical revenue, your clinical productivity. Your salary is based on your clinical productivity, because that's what makes money. So research, unless it's supported by a grant, doesn't bring in any money. And so we need money to keep the lights on and keep this place running. And so typically any research or any extra stuff I do, I am supported, 10% of my time is supported by a grant, but it's, 10% of my time is, a half a day every other week. It's not very much. And so anything really I do involving research or some of the projects I was describing is really done in my off time, or in between seeing patients or whatever, trying to fit that stuff in, or at the end of the beginning of the day. So I think it is unfortunate that medicine has gone in that direction. What you know, it might feel like, oh, I'm not rewarded in any way for giving lectures to residents or fellows or medical students. I just choose to do that because I like doing it, but I don't get extra time or pay for that.
And would you say that applies to almost all specialties, or are there some specialties where you could dodge that and, you know, have like a little bit more freedom to do?
Yeah, I think it depends on the specialty a little bit. I think it depends on the center, the academic center you work at. But from my impression about at least people who do what I do around the country, everybody talks about something called an RVU, which is a relative value unit. It's basically a widget for the amount of work I do, or we do. And, you know, I was just looking at my RVUs today, and my salary is based on that. And if I go above or below that, then my salary gets cut or increased. So it is a stressful, it can be stressful because there can be variation. And I think that's how a lot of academic centers are moving towards, is making people defend their salary based on their clinical productivity. And as a result, what happens is other things like research and education get dropped down because you don't get compensated for that. So why would you do that stuff when you're not getting compensated?
Is that because like there's a higher demand for more physicians and there's like a low supply of physicians, and maybe?
I think that's a part of it. I think also the hospitals are like, I don't want to pay a physician whatever X number of dollars if they're not actually bringing in that revenue. I think that's what it is predominantly. I would say, but you are right. I think medicine is still very much a buyer's market, meaning that there's tons of demand still for physicians in all different specialties.
Well, yeah, thank you.
Yeah, of course. Thanks for the great question. So Maggie asked, in your current position, is there any overlap with neodyatology, or is more focused on the maternal side? So great question, Maggie. So I do not, so there is overlap, meaning that we work very closely with our neonatal colleagues. They're actually technically in our department also. But I just deliver the baby and I hand the baby off to the neonatologist, and then they give me updates about what's happening, but I don't do any like resuscitation. But a large part of my job, because I'm called a maternal fetal medicine specialist, the fetal side is dealing with babies with known birth defects. So actually what I spend most of my day is doing ultrasound. So I do all the ultrasounds on pregnant women. My sonographers do them. I look at the images and we diagnose if there's any birth abnormalities. So like, for example, earlier today, I didn't diagnose it. One of my colleagues diagnosed a baby with something called skeletal dysplasia, which is like on the spectrum of like dwarfism. We've had several, you know, we always see a ton of cardiac abnormalities. So babies with holes in their hearts that we're diagnosing prenatally. And so we're giving the patients these diagnoses. And then what we do is help them work with the pediatric cardiologist or the neonatologist, whoever is going to deal with the baby once it's born to support the baby and provide any surgery it needs and things like that. So that's the fetal side of what we do, but we don't, once they're born, we don't directly take care of any babies.
I have yet another question.
Yeah, of course, Taylor.
Now, like that you're an attending, what's your typical day like, especially because you said your hospital is academically associated. So what is your typical day like now as an attending?
So, I can describe just this week for you. So, well, this morning, I did what we call my high-risk clinic. So I actually saw women who are getting prenatal care with us. I did that with my fellow, and we basically saw 7 patients this morning that have varying issues from diabetes, high blood pressure. One of my patients in her last pregnancy developed, she delivered at 27 weeks because her baby was really small, what we call growth restricted, and she developed a condition called preeclampsia, which is high blood pressure in pregnancy, and she had to be delivered early, and unfortunately that baby died. And so she's has so far had a normal pregnancy, but is obviously has high anxiety. Women with lupus. So I saw 7 patients this morning doing prenatal care, so kind of more like office visits. And then this afternoon I did telehealth consults on patients that are not getting prenatal care with me, but have high-risk pregnancy issues where their prenatal care providers, their OB-GYNs or their midwives wanted me to talk to them about certain medical conditions that may affect their pregnancy. Tomorrow I'm reading ultrasounds all day, and so we have probably 35 to 40 patients scheduled tomorrow for ultrasound. And the sonographers will do the scans, and they'll bring me the report, and I'll look at the images on my computer and then write a report, like kind of like a radiologist, write a report about a follow-up plan for them. And then that's kind of I kind of do at a week like that, mostly ultrasound, prenatal clinic, and then consults. And then next week I'm on what's called the antepartum service or the inpatient service. So these are women that have been admitted to the hospital. So I'll go into the hospital around 8 a.m. We'll go to what we call board rounds, which will have all the fellows and the residents and all the attendings on labor and delivery. We talk about all the laboring patients. We talk about anybody who's being admitted to the hospital, to the high-risk pregnancy service, what their conditions are. And then I round with my fellow. And then throughout the day, if we have any consultations, they'll call us and we'll go see the patients.
Okay, cool. Do you see mothers a lot who like are older than 35? Is that a common patient for you, or do you deal more with like high blood pressure, like obesity or anything like that?
Yeah, all of the above. I laugh that, like, to me, like being over 35 and pregnant is like not really a high risk condition. I think some of those women perceive themselves as high risk, but they are really not at high risk compared to the people I take care of. But yeah, I manage all those patients.
Okay, awesome. Thank you.
Yeah.
I have a question.
Yeah.
Could you do like a brief? Oh, could you do like a brief overview? Someone else. Could you do like a brief overview of your medical school application process and the admission?
Yeah, I can try. So you mean like how many schools I applied to and everything?
Yeah.
Okay. Yeah. So obviously a lot. I mean, again, I applied to medical school in 2004. So it's been a long time, but I think it remains competitive. I have no doubt. When I was applying, I think the acceptance rate was like 40%. So it's no doubt competitive. George Washington University, I know for a long time had the most number of applicants in the country. Not because it was the best medical school by any means, but it's a very good medical school, but because it's like in DC, which is an attractive place to live, it's on the East Coast, which is attractive. And I think it attracts people who are incredibly competitive and get in anywhere, but it also tends, has a reputation. It will accept people who are kind of, what's the word, like not unconventional. And so I think it has a large pool of applicants that find the program attractive. It has a great basis on clinical medicine and medical education. And so, and its location in DC, they also do a lot of health policy work. So that was really important to them. I applied to, I want to say like 15 medical schools, like a ton of medical schools. I was accepted at 5. And ultimately GW was my number one choice because I love DC and it was, and I think it provided a great medical education. I would say I would not be discouraged if you don't get in the first time. I don't know how many people I know who had to apply to medical school multiple times, and that's okay. It's about perseverance. And I think medical schools around the country are fairly equal, meaning that when I look at a person who's applying to residency, with me. You know, medical school is unlike law school. So my husband's an attorney, he's a lawyer. And I think there's a ton of law schools. It's pretty easy to get into law school, honestly, compared to medical school. Maybe the pre-law people would disagree with me on that. But once you're in medical school, they're incredibly invested in you staying. The classes are small. They're what, 130 to 200, versus law school classes, you know, can be 300 to 500. And so they're the fact that they have chosen you out of a pool of thousands of people, they're incredibly invested in you. And so once you get in, they are there to support you, to get you through. So I say that because I think if you want to go to medical school, I would apply broadly, because I think that's going to give you your best chances. And I think all medical schools, you get a very good education no matter where you go. Obviously, some schools will have more prestige just because of their name, but I don't think they're necessarily better schools per se. Medical education is so standardized now with the ACGME and, I think it's called ACGME, the accreditation body for medical education. And so you're going to get a good education no matter where you go. You just have to, if there's something you're interested in or some research, that's what you should excel at. But I would apply broadly. You know, I don't know what the average number of schools people apply to now, but I mean, I know for residency, med school applicants, I know apply to 30 residency programs to get to match an OB-GYN now. When I applied for residency, I applied to 12. So I think it's just getting more competitive and it's easier to apply now. The advice, sorry, I saw Mina said the advice for foreign medical grads on getting accepted to residency in U.S. medical school. Well, I'll address that later. But, you know, DO school is something that is an option. I'm not very familiar with DOs. We do, my program, our residency program here does actually look quite friendly upon DOs. Some of the best residents I worked with have been people who graduated from DO medical schools. So again, I think that is something that is, you know, kind of considered on par with the allopathic medical schools, MD schools. Foreign medical schools, foreign medical graduates, I think, still a little bit have a stigma, at least at our program, for better or worse. We don't tend to, I can't remember someone we've matched from a foreign medical school in a long time. We do interviews of them, but we don't tend to match them. I don't particularly know why, but again, I have a colleague who's a maternal fetal medicine specialist too. She works at it in Virginia, Northern Virginia. She went to St. George's, I think, and then went to a community residency program, ultimately went to Thomas Jefferson for her fellowship, and is now, you know, a great private practicing MFM out of Virginia. So I think if you are willing to work hard and apply yourself and be proactive, I think the point is just trying to get into medical school is probably the biggest barrier in medicine.
Thank you.
Yeah. So if you've had a few years after college, so Lauren asked, if you've had a few years after college before you went to medical school, did you feel behind at all, or do you wish you would have gone straight in? No, I don't think I felt behind. I think now a lot of people take some time off, and I think that's good. I mean, you know, in retrospect now, I probably wish I took a little bit more time off, because medicine is so, like, it's like you're in school forever and there's always another step to go, another training program, another whatever. And so you don't really have time to kind of, you know, just take some time off and get some perspective. So, and I think people who take some time off gain more perspective, and I think bring more enrichment to the medical class. I do live in DC. I live in Chevy Chase, DC. Madeline. Taylor asked, how much of a say do you have in your application of a job? Is mostly what jobs? Okay. So to ask about the job, so jobs, when you start applying for a job, so in residency and fellowship, it's all a match. The match is a really complicated process. So basically, you know, you put your application out to a bunch of schools, you interviewed a bunch of places, and then one day you get a letter that says this is where you're going, and you're matched. You create a list of the programs you like, the programs create a list of the people they want, and then this computer program matches everybody. It works in favor of the applicant, but it's quite complicated. So you basically have no choice. And I always tell people when they create their residency, fellowship, and match list, never put a place you don't want to be at, because you can match there. That happened to a friend of mine. She matched at her last spot she wanted to go to, and to this day ended up leaving that program. And I always asked her, why did you put it? She's like, well, I did not want to match. I'm like, I get that, but like, you match it somewhere you ultimately left. But that being said, when you have a job, you have much more flexibility. I mean, you basically, for us, my graduating fellows right now, one is joining my practice here, but she, had 3 or 4 offers all around the country. So when I graduated my fellowship, I was given an offer to stay at San Diego, but ultimately we wanted to be here in the DC area, and had 3 job offers here. So I decided to stay in academics and stay here at MedStar. If you're planning to go to medical school right out of college, but don't get in, what are some good ways to spend the year, giving you a better chance in the next applicant cycle? So I think that's always something good to think about, Morgan. I think you need to do something that's going to enhance your application. I think you have to really critically look at your application and say, why did I not get in? So did I not get in because maybe my GPA was not as strong as I would have liked it to be? And so if that's the case, maybe doing like a post-bac program would help you out. So I know at Georgetown University, we have a program where, I forget what it's exactly called, but several of my friends did it in my medical school, where it's basically like the first year medical school, and you take all the classes and you work incredibly hard, but you want to get a good grade. And most of those people are almost guaranteed admissions to Georgetown or to medical school. So if you feel like your application is weak because of your GPA, then you should probably do something that's going to bolster your GPA. If you feel like your GPA is good, but maybe you're missing clinical experience or research experience, then you need to find something like that. One of my friends in medical school who I always admired, who's now a cardiothoracic surgeon up at Mass General, he worked for Operation Smile for 2 years. He was like a coordinator of missions, and Operation Smile, is the group that does the repairing the cleft lips and palates. And so he just worked for them. It was, he wasn't doing anything medical, but he gained so much perspective and just experience with that, working at a nonprofit who did a health-focused thing, that, when he ultimately applied to medical school, that was, incredibly attractive for him. I've had friends that go on to do, something like I did, like a master's in public health, before they went to med school, because they feel like that, or, people do, if you like statistics or math, master's in biostats, a master's in public policy. So I think there's ways to, a year off, you can only get better, right? You can only do more to improve your application. But I think you have to critically look at application either with a mentor, or somebody who can help you critically look at it and see how can you improve things. A good example of what's happening now, and I don't know, Mohammed, if y'all are doing this in North Carolina, but one thing that the med students at GW have done, which I thought was really ingenious, is how it's so hard for the elderly to get access to the COVID vaccine? Like, they gotta log on, and then I don't know if that happens in North Carolina, where it's like impossible for them to sign up for an appointment, and they're all stressed out. So what GW did, which is my med school, is if you want somebody to help you, like a young person who knows technology, then you just give them your name, your information, and they log on at whatever time it opens up and get you an appointment. And then they've even been driving people to their appointments. And I think that's an amazing service opportunity that I don't know if that's an issue down in North Carolina, but it's been great for people who live in my neighborhood, because we live in a more residential area of DC that have a lot of elderly people. And so That's been a really nice thing I've been seeing people doing recently. So that would be kind of a cool thing to do. What kind of clinical experience did you do in college for your med school application? So in college, I did, I did study abroad twice in college. And one time I did like, I don't know if they still do it, but there was like a program in India. So I did that for half the summer. And then the other half of the summer, I had the opportunity to go to Malaysia, which is where my mom's family's from, and do some work there with the Malaysian healthcare system. It was mainly an observership, but just seeing how their healthcare system worked, seeing how more of a nationalized system worked, and have experience with that. I also did, I did Operation Smile as a medical student. I remember also doing, I don't know if this was in high school, but I used to work at Wake Med Hospital, and I had a physician I worked for there who allowed me to shadow her when she was on call. She was an emergency medicine physician, so I just worked with her there doing that. And I had 3 physicians in my family, so I didn't work with them, but I had exposure to medicine that way. But I think my angle in medical school was really my health policy background and my experience in policy and fusing policy and medicine and my interest in that. I think that was really what made me stand out as an applicant when I applied. Do med schools explain what you might be missing out of application? So Neil, unfortunately they don't. And I don't know, they don't give you any feedback. We don't give feedback to residents we don't match or fellows that we don't match. That's an unfortunate part of the process. And so, I don't know at NC State if you have, a mentor there who can look at it. Again, Mohammed, I was so happy when he reached out to me. I'm happy to, anybody wants like after you apply and you end up not getting in, I'm happy to sit down with you and look at your application to see if there's any ways that at least my perspective, you can improve it.
Something I'll add on about that is that different med schools have different policies when it comes to giving feedback. So, like, let's say if you were getting rejected from somewhere, you should definitely like give them a call or email them. And the worst thing they can do is say like, "No, sorry, we don't give feedback."
Yeah,
It's definitely worth a shot to at least like call them or email them. And otherwise, like Dr. Overcash said, like we have Dr. Easterlin. He's our pre-health advisor at NC State. So obviously he can give feedback. If it's something immediate, you can set up a meeting with me and I can give feedback as well.
Yeah, that's a great suggestion, Mohammed, is that, right, worst case they say, no, we won't give you feedback. But I've never had somebody email me that, and I'm sure if somebody did, I would take the time to look at their application and give them feedback, because I think that shows insight by the applicant and showing that they want to improve themselves, and that takes a lot of courage to do, and so I think that can only help you.
Exactly.
So you mentioned this already. I'm not sure you mentioned this already, Maggie said, but what opportunities did you pursue in undergrad that fused both policy and medicine? How did you go about finding these opportunities? So when I was at NC State, I worked, so my summers off, that's when I tried to pursue some of the more of the infusion of the policy. So after my junior year, I interned for the summer in DC. I interned at something called the National Association for Social Insurance. It's a nonprofit that basically does policy analysis on social insurance policies, so Medicare, Medicaid, Social Security, long-term care insurance. And so that was a very kind of policy-focused job, but it was on health policy. And so that's what I did after my junior year. There are tons, I mean, if you never spend some time in DC has so many internships, whether that's you want to work for a congressperson or one of the, HHS or one of the nonprofits. I think even having if you can't come to somewhere like DC, trying to find a local policy program at, the North Carolina Department of Health, or any, health department in any state, would be an opportunity. So that's kind of what I did in undergrad. And then I explained already the program I did in Malaysia, and then my senior thesis project in political science was about long-term care insurance. So.
And yeah, I had a question about how physicians are, I guess, approaching shadowing right now, or if hospitals have like some type of rules against student shadowers at this time. Because I know a few months ago, like, there were really no doctors accepting shadowers.
Right now we are, at least at my institution, we are accepting. I don't know about. Recently, we had somebody who, I'm blanking now, who was visiting from another institution that we did allow to come. But I think you're right, that it's hard now in COVID, because if you're not vaccinated, and but as more people get vaccinated, I think that will open up more. But yeah, it is hard right now.
That was the second part of my question. I was going to ask if it would make a difference if you were vaccinated, if the student was vaccinated.
I mean, I'm sure it can't hurt.
Okay.
I think another better thing is, like, so much of what I've started doing now is telehealth. You don't have to be together for telehealth. So maybe if there is an opportunity to shadow a doctor and sit in on one of their telehealth sessions, that's something that I think would be advantageous.
Gotcha. Okay.
But yeah, COVID has definitely put a stop on a lot of those things.
All right, we have time for one last question, and then, yeah.
Can I ask a question?
Yeah, I guess that's allowed.
So are most people like committed to medical school, or are they thinking, or are most of you like in the current application process, which I guess we're in February, so I assume most people had applied. If you're applying for next year, are currently interviewing or have finished interviews. PA school, that's great. So the person who says, I really want to do it, but I'm scared, it's hard, but you won't regret it ever. I don't think. I think it's still one of the most rewarding careers that exist. But it's a long road. I don't know how many patients ask me all the time, how long did it take to become a doctor? My kids ask me, how long did it take to become a doctor? And I tell them, I'm in grade whatever, 25 is when I graduated. They laugh, but it's true. The MD PhD program, now that is a long haul. Those are for committed people. Those are really for the future physician scientists, of which I am not, but those people are remarkable. Yeah, I think if you have any interest, what Jessica said, getting my MPH, I think it's a great option before going in. Taking gap year is great. My one advice when you interview is, now you're interviewing on Zoom. I have interviewed a ton of people on Zoom. And the one thing, and maybe I'm doing it too, is like the one thing that's incredibly distracting for people is if you constantly are like looking away. I don't know. It's like we've had a few applicants that's all they do, and it's like it drives us nuts, because it's like they feel like they're not focused. And then lighting helps. So buy a ring light, buy some type of lighting. And obviously still look professional, wear your suit. And yeah. But Zoom interviews are I think are what's going to happen for a while now. It's a lot cheaper than going to all these places.
That's true. All right, well, Dr. Overcash, thank you so much for your time. Taking the time out of your busy day to come answer a lot of our questions. Just to wrap up.
Can I put my, Mohammed, do you mind if I put my email in the chat in case anybody has any questions?
I was gonna email you and ask if it was okay if I sent out your email.
Yeah,
but yeah,
I'll put it in the chat, but please feel free to distribute it. So, and I just put my Gmail, and then again, I'm at MedStar.
Yeah, definitely. And I'll send out an email with that information as well. But thank you so much for taking the time out. For everybody else, if you need to fill out the attendance, I just sent the Google form in one more time. Other than that, thank you so much, Dr. Overcash. For the rest of y'all, see you guys in 2 weeks.
Oh my God, this is great, Mohammed. Thank you for inviting me, and I'm again happy. Oh, I think I didn't send my email. I sent it just to somebody specific. Let me just hold on. Let me just write it in here again. But this was wonderful.